Good evening. I am presenting my paper on the protocol that we have developed for community-based intervention in chronic non-specific low back pain. To introduce the topic, the chronic low back pain is a common public health problem all over the world. Conservative therapy is the initial treatment strategy in chronic low back pain, and the cornerstone of conservatism in back care is core muscle strengthening. And a host of exercises are prescribed for this, but we have found that many of us have found that many of these exercises are not easily done by patients in Asian countries. Exercise prescribed for the Western population are not suitable for most of the population in suburban India. And we have also observed that when we ask them to do some exercises, there will be exacerbation of symptoms and they drop out of the exercise therapy. So it is important to train patients in the correct way of performing the exercise. Exercise should be easy to be trained and performed and with minimum resources. And ICMR in its study has found that only 10% of the Indian population engages in recreational physical activities. Hence, we developed our core stabilization protocol, which we call as the Trivandrum community-based core stabilization protocol. So the aim of the study was to test the effectiveness of the protocol that we have developed in patients with chronic low back pain. So patients with chronic low back pain of more than 3 months duration were enrolled in the study. The age group was 18 to 70 years. We excluded patients with the fractures, tumors, high-grade listhesis, infections, patients with psychiatric illness, and patients who were enrolled in the study were expected to have minimum higher secondary education because we thought that it was easy for them to understand the philosophy behind the protocol. Lots of core exercises are in vogue. So we analyzed the various core programs that are there, and our research team zeroed in on 12 sets of exercises based on their easiness, reproducibility, and practicality. And we divided this into 3 groups: the basic set of exercises, intermediate set of exercises, and the advanced set of exercises. These are the basic set of exercises: the abdominal tights, partial curls, pelvic tilts, and the extension exercises. The intermediate set of exercises are the supine bridge, the prone bridge, the side bridge, and the quadruped exercises. The advanced set of exercises are the exercises that we have done in the intermediate set, but here we are doing these exercises over an exercise board. That is, the platform that we are doing is unstable. So these are basically simple 12 sets of exercises that we have zeroed in on to. And the basic flowchart how the back care clinic works is: the patient is assessed by an orthopedic surgeon with some interest in spine. He examines the patient, reviews the images, determines whether it's a non-specific chronic low back pain, counsels the patient, describes the nature of the disease and anatomy of the disease. Then a nurse who is trained to assess the patient on Oswestry Disability Index, and one more tool that we use, the KBS. This is the Keel Back Startup tool. This is important to understand the psychological make of the patient. Then the back therapist or a trained member of the team identifies the pain-free range of motion of the spine, targets the core muscles, and starts the patient on the basic set of exercises. The patients are encouraged to do this at home, 20 repetitions twice daily for 7 days. After a week, the patient visits the clinic again. Here again, the weekly assessment of the OD is done, and again, depending upon the progression of the patient, the next set of exercises, intermediate or advanced set of exercises, are taught to the patient. So basically, there is only one weekly visit to the clinic. The patients are encouraged to do the exercises and to have a positive outlook by phone calls, pamphlets, and YouTube or WhatsApp videos that the clinic has prepared. Mention about the Oswestry Disability Index. This is a 100-point score into it is taught 10 domains, and the important thing here to know is that the score is less than 20, there is no disability. 21 to 40 is moderate disability, and 41 to 60 is the severe disability. Then the Keel Start Back tool, just 9 questions that we have to ask, with the patient has to give an yes or no answer. The questions from 5 to 9 are actually the ones that give whether the patient is emotionally distressed or not. So if the patient is having a total score less than 3, they become low risk category. If the patient is having 4 or more, they can be medium risk or high risk, depending upon how much they answer in the questions 5 to 9. This is important. We have found that in our clinic, it is very easy to stratify the patients. The low risk and medium risk group, they go directly to the TRICCS rehab program, while the high risk population, they go to a cognitive behavioral therapy with TRICCS rehabilitation. So the materials and methods, 80 patients were enrolled, 73 were available for follow-up. Mean age was 40 years, close to 40 years, with male-female ratio of 40:60. And the initial mean ODA score was 46.4 with the moderate to severe disability. That was the thing. And the KBA score was less than 3 in 69% of population. They were 3 to 6, the medium risk in 28.8% of population, and 3%, close to 3% had more than 6 as the initial KBA score. We did the major outcome variable that we studied was a trend in the reduction of ODA scores. So we used a host of statistical analysis like ANOVA, the t-test, correlation coefficient, and the chi-square test, depending upon what parameter we studied. And let us look at the results. So look, the initial mean score that when we started for the when the patients were enrolled in the study, it is 43.4, and over a period of 6 weeks in the low risk category, they went to 24.6. That is the mean outcome score that was obtained. When we looked at the high and the medium risk group, they were also able to attain the similar improvement, but they took more time. On an average, they will take 12 sessions. So what were the factors that were associated with the reduction in the ODA scores? We studied different parameters like the age, sex, the body mass index, all those parameters we studied, and we found that only important thing was the KBA score that the patient had when they started the exercise regimen. So this was the most statistically significant parameter. So it was not the age, it was not the sex that was important. And again, the independent predictor for the rate of reduction of ODA score, the most statistically significant value was for the lower the KSB score at the start of entry into the exercise regimen, they get good reduction in the ODA score. Again, we found that at 6 weeks, those patients who improved but who still had 20, 22, 23, 24 like that disability, they were patients whose age were greater than 40 years, starting ODA was more than 40 years, and the KSB score was more than 3. So from the study, we know that these patients, this category of patients, they should be counseled early, and from the beginning itself, once you counsel them, they fall on track. So coming to the discussion of this one, so core muscles of the body are the internal bracing of the spine. They are our abdominals, they are the internal external oblique muscles, the transverse abdominis, the posterior erector spine, a group of muscles, and the gluteus medius or the pelvic floor muscles. Whenever you start the exercise regimen, it is important that you identify the pain-free range in the neutral zone. This is important because every patient with a chronic lower back pain will have at least a small arc of motion in which the patient does not experience pain. So that has to be increased. So the rationale for developing into 3 sets of exercise, basic, intermediate, and the advanced, was that we are not proposing any new exercises, but we have picked a few exercises that are easily for the Asian population and proposed a protocol which is effective in achieving improvement. As patients become accustomed to the exercise regimen, their pain-free range increased. The basic set of exercises is aimed to improve the pain-free range of motion. It concentrates on the transverse abdominis. The intermediate set of exercises, they concentrate on the extensors, rectus abdominis, gluteus medius, and the obliques. The advanced set of exercises make the platform unstable, so that they have to achieve proprioception and neural adaptation. We looked at the role of mental status in the patient in chronic low back pain recovery. And for this, we used the tool, the Keel Start Back tool. So if the patients are scoring more in the Keel Start Back tool, psychological intervention could be started from the initial visit itself. And also, we can counsel them for a longer duration exercise regimen from the initial visit itself. This is the first study on the Indian population which used Start Back the start back training tool as a screening tool with the aim of finding out whether high-risk group behave differently in their outcome. And we have found that patients with higher SBT values tend to have a protracted recovery. So to conclude, disability due to chronic low back pain is a growing healthcare task all over the world. Hospital-based settings to treat this CLBP is expensive. Going to therapy clinics is expensive for the patients who have to go for a daily living. So in developing the TRICCS protocol, our attempt was to make a simple and practical management algorithm which can be easily implemented in the community using the 3-tier health system which is robust in the state of Kerala. Our results show that TRICCS protocol is quite successful and selected patients can be offered the service of behavioral therapies from the beginning itself so that the days of chronic pain and disability can be reduced significantly. Thank you.